So, bronchogenic tumor. A very important highlight about them is that they are the most common cause of death from cancer, and approximately 2 million people die per year because of these tumors. So, now let's move toward the etiology of the primary tumors of lung. As we all know that cigarette smoking is the most common cause of cancer, but in the recent years, with the decline in the smoking, the cancer in the smokers is also decreasing, and the non-smoker disease is increasing in number. Passive smoking, radon in the environment, and urban pollution are also causes of lung cancer. Similarly, occupational irritants, which includes beryllium, arsenic, asbestos, they can also contribute towards lung cancer. Now, pathology. So, the tumor can arise from the bronchial epithelium, or it can also arise from the mucosal glands. If it, if it affects the large bronchi, then because of the production of early symptoms, the disease is early detected. And if it affects the smaller bronchi and bronchioles, then it takes a very large form and usually detected late because it is mostly without symptoms. So if there is a peripheral squamous tumor, then it can undergo central necrosis and cavitation can form, which usually appears as an abscess on X-ray. They can invade pleura, chest wall, and can also involve mediastinal and supraclavicular lymph nodes, either directly or by the help of lymphatics. They can also metastasize to the liver, brain, bone, adrenal gland, and skin by the help of the blood. Now let's move toward the clinical features. So if I talk about the clinical feature, then cough is the early symptom. Yes, cough is the early symptom. First it is dry, and then with time it becomes purulent. That is mostly by secondary infection. So if smokers and the cough pattern is changed, and there are new symptoms like weight loss and anorexia, then bronchial tumor can be suspected. Hemoptysis, yes, is also common, especially in central bronchial tumors. And differential diagnoses here include bronchitic infection and sudden massive bleeding is can occur occasionally by the invasion of large vessel, but not common. Now, bronchial obstruction. Yes, the clinical and radiological manifestations depend on the site and extent of obstruction, recurrent infection, and coexisting lung disease. If there's complete obstruction, then collapse, obviously, and breathlessness, mediastinal displacement, dullness to percussion with decreased heart sound, they are mostly present. But if it's partial, yes. If there is partial obstruction, then monophonic unilateral wheeze that fails to clear out with cough. Um, Mostly the presenting complaints are pneumonia and abscess, and if the pneumonia is slow in recovery or it reoccurs at the same site in smokers, then it suggests that cancer. Similarly, stridor can occur if there is narrowing of the larynx, trachea, and main bronchus. Compression from malignant enlargement of subcarinal and paratracheal lymph nodes. It can also contribute toward the stridor. Here we have four types and their contribution. Like the adenocarcinoma is contributing to approximately 35 to 40% towards the lung cancer. Squamous carcinoma, squamous cell carcinoma 25 to 30%, small cell 15%, and large cell 10 to 15%. Now, breathlessness, it can occur from collapse, pneumonia, pleural effusion, and phrenic nerve compression. Next is the pain and nerve entrapment. Yes, if the pleura are involved, then pleuritic pain can occur, and because of the involvement of intercostal nerve, there can be pain in that thoracic dermatome. Similarly, if in case of the apical lung cancer, Horner syndrome and Pencroft syndrome can occur. Now, next is a mediastinal suppress. It includes like esophagus is a component of mediastinum. So if it is involved, then dysphagia occur, and pericardium involvement results in effusion and arrhythmia. Here is pericardial effusion, and SVO obstruction causes swelling and edema. Similarly, left recurrent laryngeal nerve. Um, if it's involved, then there is alteration in the voice, and bovine cough can occur. Similarly, supraclavicular lymph nodes become palpable and enlarge. Now, if there is metastatic spread to the brain, then focal neurological defects can occur, epilepsy, personality changes are present. These all depends on the organ that is involved. Weight loss and lassitude anorexia, they are systemic symptoms. Now, clubbing. Yes, clubbing can occur, and it's because of overgrowth of soft tissue of terminal pharynx. And hypertrophic pulmonary osteoarthropathy, it can also occur. And it's actually the painful periostitis of the distal tibia, fibula, radius, and ulna. Here, local tenderness occurs, and along with the pitting edema, and on the X-ray, it's visible like the subperiosteal. There is subperiosteal newborn formation. Others include non-metastatic extrapulmonary effects, and here we have endocrine, which are SIADH, ectopic ACTH hormone secretion. Similarly, hypercalcemia, carcinoid syndrome, and gynecomastia, they can occur. In case of neurological, polyneuropathy, myelopathy, cerebellar degeneration, and myasthenia occurs. Others include nephrotic syndrome, eosinophilia, polymyositis, dermomyositis. And these are all about bronchogenic tumors, about their etiology, pathology, and clinical features. Hope you will like this video. If you like this video, click on the like button and also subscribe to the channel. Thank you so much for watching this video.